Yeah, so thank you for the introduction. Like Dr. Chu mentioned, want to highlight a lot of the work that's been done here with intrarenal pressures, and at the AUA this year at the Endro-Urology sessions, intrarenal pressure and kind of suction technologies during ureteroscopy has definitely been a hot and evolving topic. And over the past kind of 1 to 2 weeks here, we've been slowly using the Cleopatra sheath, and some of the residents have also been able to try it and really think it's a big game changer. I'd like to show you some of the evidence, and we do have a few videos around that. So just kind of a quick layout. I just wanted to review the guidelines on ureteric and renal stone management, how it relates to some of the complications you see after the procedure. I want to review factors looking at postoperative ureteroscopy sepsis, look at the evolving role and evidence around intrarenal temperature and pressure, and finally go over some of these newer technologies that you may be seeing around soon. So as we all know, kind of stone prevalence is increasing in the general population, around 10% in both genders. Traditionally, it's more common in men, but kind of the rates are equaling out. We do see a increasing rate, most likely due to associated with increase in diabetes and obesity in the population linked to certain metabolic factors. Once patients do get stones, there is about a 50% chance of recurrence within 10 years. And for patients that are on pharmacologic management, they aren't very compliant with their treatment. So stone disease can have a large economic burden on the population. Studies from the US quote anywhere from direct and indirect costs of more than $5 billion a year. That's what patient care and loss to work time to the patient as well. So we know that stone disease is prevalent, it's increasing, and it's here to stay. So what can we do to better understand that? So this is the CUA guideline management of ureteric stones, last updated in 2016 or 2021, sorry. Ureteroscopy is the mainstay of surgical treatment with high stone-free rate and low complications. It's considered first line for treatment of ureteric stones, renal stones smaller than 2 centimeters, and kind of wide variety of more complex patient classes such as pregnancy, peds, and the comorbid patients. With mentioning for ureteric access sheath, it says there's no impact on stone-free rate or complications, but we'll kind of provide some evidence a bit on that later, but may improve visualization, reduce intrarenal pressures, and facilitate fragment removal. The EAU guidelines actually has a small section on post-ureteroscopy complications. It quotes the rate of complications anywhere from 4 to 25% after ureteroscopy. And a post-op sepsis rate of around 5%. More severe complications are relatively rare, less than 1% with avulsions or strictures. They do mention that higher intrarenal pressures do predispose to complications. The guidelines say there's currently no accurate way to measure it intraoperatively, but there are some newer single-use scopes on the market that do have both temperature and pressure sensing capabilities we'll kind of talk about later. And under the PCNL section, I think it's also applicable to ureteroscopies. They mention as long as your intraoperative pressures are less than 30 millimeters of mercury and you have good postoperative drainage, it can help prevent postoperative sepsis. This graph just nicely illustrates the portion of ureteroscopies that have been kind of done over the previous few years as kind of international study, and it showed that over the last 2 decades, the proportion of ureteroscopies done have significantly increased, while proportion of PCNL has stayed about the same, and shockwave lithotripsy has gone down drastically. Ureteroscopies have increased from around 46% of stone procedures back in 2007, now up to around 60% in 2017, and that's probably gone even up higher now. I think a lot of this has been due to the improved visualization and maneuverability of scopes, your newer lasers and single-use scopes. So more ureteroscopies are being done now. And so just trying to better understand risk factors for postoperative complications, particularly sepsis. A lot of this work was done by Dr. Pojani and Dr. Chu here. This was the first systematic reviewed meta-analysis to focus on urosepsis. A lot of their prior studies, they've been quite heterogeneous in their definition, ranging from anywhere from postoperative fever/UTI all the way to septic shock. But this reviewed 13 studies, 5 of them being prospective. looking at patients undergoing ureteroscopy. They defined urosepsis as anyone with suspected infection and SIRS criteria, and they found a pooled incidence rate of 5%, kind of consistent with the European guidelines. They identified 6 risk factors. The bolded ones had stronger levels of evidence. So patients who do have a preoperative stent, patients who have a positive preoperative urine culture, and age were risk factors, and kind of with weaker level evidence, the length of the procedure, and more comorbid patients, so diabetics and those with ischemic heart disease, were also found at higher risk for sepsis. Other studies have also looked at this. This one in particular looked at SIRS criteria after ureteroscopy. But I just wanted to highlight because they found some factors that were associated with intraoperative things that we can control, such as irrigation flow rate and irrigation volume, and also the caliber size of the ureteric access sheath, which will kind of come into play a bit later. This is kind of a continuation of the previous study by Dr. Chu, but this one looked at retrospective claims analysis of the IBM market database from the States. It's a commercial database covering kind of private health insurance for employers and health plans for 215 million people in the States. Over a 5-year period, they had 100,000 patients undergo ureteroscopy. And from that same database, around a similar rate of 5.5% sepsis and similar risk factors you can see with prior episodes of sepsis, older age, and diabetes being risk factors. But they also broke it down looking at the sepsis cohort compared with the non-sepsis cohort and looking at their kind of impact on the healthcare length of stay and ultimately cost to the healthcare system. So if patients got septic after ureteroscopy, they did have an increase in inpatient. Almost 95% of them managed as inpatients. 35% of them needed increased level of care in the ICU, and their increased length of stay was around kind of almost 7 days. I do notice one of the non-sepsis cohort is also quite long. Not sure why it's 3 days for a standard ureteroscopy, but you can see kind of the medical costs. It's almost 50,000 USD. So almost kind of 2.5 times what that is for a standard ureteroscopy. And then they looked at it further. We're looking at the 30-day mortality rate after ureteroscopy if you did develop sepsis compared to if you develop severe sepsis. For severe sepsis, they use the ICD-10 classification. So any patients with sepsis and acute organ dysfunction. So basically anyone that ended up in the ICU. And what they found, so patients that underwent an uncomplicated ureteroscopy didn't develop sepsis, mortality rate was very low. But if you did develop sepsis, it's at 0.82%, and severe sepsis, the 30-day mortality rate was almost 2.5%. So from the guidelines and from those studies, there are certain factors you can change and alter intraoperatively that can help minimize your postoperative sepsis rate. So patients with prior sepsis, having a prior culture and treating them before and after with antibiotics can help. Patients that are pre-stented will look at, and intraoperative factors such as temperature and pressure can help. And then I listed preoperative alpha blockers, not in the traditional sense, but in the fact that it may help facilitate insertion of the access sheath and instrumentation. So with preoperative alpha blockers, we do know there's abundance of alpha blockers in the ureter, but predominantly in the distal ureter. It can facilitate access and instrumentation. We do know from the literature there's about an 8 to 10 failed access rate with ureteroscopy. The CUA guidelines state that preoperative alpha blocker usage may improve intraoperative and postoperative outcomes, but they don't really delve into the specifics. The optimal duration is uncertain as well. Lots of studies, they've been anywhere from kind of 2 to 3 days to weeks, so the exact duration is unknown. This was a meta-analysis done from Dr. Pace at U of T, looking at preoperative alpha blocker usage prior to semi-rigid ureteroscopy. With over 1,300 patients, their duration ranged all over the place as well, preoperatively, from anywhere 3 days to about a week or so, but they found a 61% risk reduction in need for ureterodilation. They found increase of stone-free rate at 4 weeks slightly, and also they were more likely to reach the stone as well, and a slight reduction in OR time. In regards to stenting, for CUA guidelines mention routine preoperative stenting is not necessary for most cases, but it can facilitate ureteric access, sheath, and instrumentation during your subsequent procedure. But there are conflicting data around stone-free rates and complication rates. But it's commonly placed for sepsis, pain relief, infection, AKI, or limited OR resources. But we do know, kind of as we chatted about last grand rounds, that stents aren't without their own kind of harms and downfalls. We do know almost all patients do experience impact on their quality of life, dealing with stent colic, hematuria, and increased risk of infection as well. So we do know a lot of patients are being stented. So when is the optimal time to do your ureteroscopy afterwards to prevent your sepsis rate? So from a lot of kind of the animal models done in pigs, you do know kind of at 1 week after stenting, that's when you get your maximal dilation around 3.8 French increase in lumen size. Looking at a lot of the pro-inflammatory factors, and the dilation happens within the first kind of 2 to 5 days. So after 1 week, that's when you get the most dilation, but afterwards, when's the optimal time to treat things? So this was a study done from Israel, trying to figure that out. It was a prospective study, 1,200 patients undergoing unilateral ureteroscopy, and almost half of their patients were pre-stented. And their medium stent build time was around 62 days. So they did have a good kind of length or variety of different stent in dwell times. And they found an almost 5 times higher rate of their pre-stented patients becoming septic postoperatively within 48 hours. And what they did is they looked at the sepsis rate depending on how many weeks after your initial stent was placed, the ureteroscopy was done. If your ureteroscopy was done within a month, the sepsis rate was around 1%. At around 2 months, it was around 5%. 3 months, 5%. And then greater than 3 months, the sepsis rate was around 10%. So they found the infection rate 5 times higher if subsequent ureteroscopy was performed after 30 days. So it seems like the sweet spot is kind of after that 1 week where all of your physiologic changes are done, and then hopefully up to 4 weeks before you see an increase in postoperative sepsis rate. But I know in the real world, that's not always possible with kind of scheduling and limited OR resources.
I think you're correct to the fact that a lot of them had infection in the first place. Why you got this kind of
Yeah, I think that's also a major risk factor. This can be kind of, I think on the previous slide, around 17. So around 7, and then kind of almost 30% of these stents were placed for like septic patients. So I think that may be contributing, but you can also say if you treat the septic stone sooner, there may be less of a chance of them kind of getting septic again after their subsequent procedure, but that's definitely a confounding factor. And then for ureteric access sheaths, they were initially developed similar to the AMFAT sheaths for PCNLs. They facilitate access to the collecting system, multiple reentry, helps decrease your intrarenal pressure, improve your visualization and drainage around the scope. There's controversial data on stone-free rate for the traditional access sheaths, and also a risk of ureteral damage and need for stenting afterwards. The most common size that we use here is 14 French, which kind of accommodates all your scopes. And there are smaller scopes available with maybe a theoretical less chance of injury, but there's also kind of less flow around it with your pressures. So next, I just wanted to review some of the evolving evidence around intrarenal temperature and pressure. So they've always kind of known that with irrigation and lasers, you can increase your temperature, increase your pressure, but what do you really make out of all of that? What's really the clinical relevance and long-term implications? So this is a nice review by Dr. Traxler in Paris, looking at the developing role of intrarenal temperature. Intrarenal temperature itself, it's a related property of lasers. The way they act, their mechanism of action is photothermal. The lasers themselves are actually not very efficient. You do need high power to break up the stones faster, but all this extra energy is absorbed by the surrounding water. So it does increase your temperature. So the fluid temperature is proportional to the laser power. and the tissue damage depends on temperature and the duration of time it's exposed to that elevated temperature. From the medical literature, they kind of set an arbitrary threshold of 43 degrees Celsius for 240 minutes as their temperature for thermal injury. But I think that's due from people with high fevers and such like that. I don't know how applicable that is necessarily to the kidney, but their thermal dose is non-linear. For example, at 53 degrees Celsius, their threshold is only 15 seconds. So the temperature increase does depend on the laser power you're using and then your irrigation rate. Lots of things can affect this, such as if you're using a larger laser fiber, if there's any instruments in your working channel, and also kind of the size of your channel, and also the method and your irrigation flow rate. So there have been bench studies trying to better study temperature with respect to your irrigation rate. So this was a bench study with the holmium laser, looking at different energy settings and also different flow rates and looking at the associated temperatures. With their maximum pressure irrigation at 100 mils per minute, only their highest setting of 1 joule 20 hertz at temperatures higher than 30 degrees. If you halved your pressure irrigation, they did see more elevated temperatures at around 43 degrees. And if your irrigation was off completely, any of the energy settings, you did see significantly higher temperatures greater than 43 degrees. So this kind of just highlights a few things that we do try to teach when you're lasering is you don't want to fire the laser continuously. You want to give time for the irrigation to kind of cool things down. You do want to limit your energy use to kind of as much as you need to efficiently kind of dust or fragment your stone, just because any of the settings long enough will raise the temperature. And finally, using room temperature or even cooled irrigation can help cool things down. Yeah, then tissue damage, we'll kind of see a bit later kind of what exactly they mean by tissue damage. There's still not a lot of great evidence on like long-term effects of these elevated temperature, but they have seen initially on like histology slides and some animal models that you do see renal tubules and kidney damage. There's a study that shows a couple slides in a bit. Yeah, there are some kind of single cases, like a case series popping up that have shown kind of burnt kidneys and people that use a lot of energy without access sheaths. But some people have been using large energies for a while, and not everyone does end up getting a burnt out kidney. But I think this may be contributing. So this one just focused on the difference between the thulium fiber laser and the holmium YAG. And they kind of looked at the time to laser a standard stone on a bench study. They found that the thulium fiber laser did have a shorter laser time. It was more efficient, but it did generate higher temperatures. They did find that the way the thulium fiber, the fibers themselves can get much smaller, and then the frequencies can get much higher, up to around 500 hertz. And then they saw significantly higher higher temperatures with the higher frequencies. And people have been trying to study or figure out kind of what exact is the nature of the kidney injury that it can cause. Some people have looked at urinary biomarkers for markers of inflammation and kidney injury. The study kind of looked at kidney injury molecule 1 and gallon beta 2 macroglobulin to patients after ureteroscopy. They looked at urine collection kind of preoperatively, 1 hour postoperatively, and 10 days after. And then they found a pronounced rise in both TFL and holmium YAG after ureteroscopy compared with kind of no laser. And that kind of lasted for around 10 days afterwards, but the real long-term clinical implications still kind of remain to be seen. Switching gears to kind of intrarenal pressure. We know kind of pressure through a rigid tube is influenced by the pressure gradient between the two ends, your viscosity, the length, and the diameter. That's kind of Poiseuille's law going back to undergrad physics. But with a collapsible tube, you also have the transmural pressure in the surrounding environment that can affect the pressure as well. So with elevated pressures, there's kind of 4 kind of backflow mechanisms that can happen from the kidney. You can have pilotubular, where that kind of opacifies your medullary pyramids, pilosinus, where you can have fornicule ruptures, pilolymphatic, and then pilovenous. Really, the pilovenous is kind of what we're concerned about with the increased pressure and the bacteria going kind of into your bloodstream theoretically. So baseline intrarenal pressures they found have been around 0 to 6 centimeters of water, and pilovenous and pilotubular backflow can occur greater than 30 centimeters of water. A lot of the studies will use either centimeters of water or millimeters of mercury, which we may be a bit more familiar with. 1 centimeter of water is around 0.7 millimeters of mercury. So this study kind of tried to find out what are normal intrarenal pressures and what intrarenal pressures you normally see in different physiologic or pathologic states. But this was a review of animal studies, mostly in dogs and pigs, but the ranges themselves may not be too relevant, but it does kind of get the point across. So they found similar in unobstructed kidney, 0 to 2 centimeters of water, with diuresis around 30 centimeters of water. Chronic kidney disease, it did find significantly elevated pressures over a long time, over 68 to 95 centimeters of water. And similar to the last study, pilovenous, anything over 40, and then pilosinus doesn't occur to a much higher when you're in the 80 to 95 range. And then they've seen kind of renal cellular imaging within 1 hour of studies after in a lot of these animal models with elevated pressures. This was a study kind of done at Stone Center here, looking at kind of in clinical situations, how these elevated pressures relate to post-operative complications. So there were 5 of these being clinical. And what they found is that no study reported an increase in complication rate when the intrarenal pressure was less than 30 millimeters of mercury or 41 centimeters of water. And they also give the other criteria if less than 20 millimeters of mercury for less than 10 minutes. But I think the less than 30 millimeters of mercury is more inclusive. So that's kind of the magic threshold or sweet spot that most studies do, try to keep the pressures underneath where it's considered generally safer. However, there is large variability seen across intrarenal pressures across upper tract procedures. This just highlights kind of the wide range of pressures you can see. So with semi-rigid ureteroscopies, the pressures can range anywhere from 7 to 150. Then once you get up to the kidney, because you do have that kind of reservoir where you can keep flushing fluid in, the pressures can get significantly high up into around 500 without an access sheath. Studies have shown that pressures do significantly come down with an access sheath, and also depends on your method of irrigation. They found with a hand pump or manual pump, the pressures were the highest, and with a lot higher spikes of it when you're initially pushing it. There is theoretical higher intrarenal pressures with mini PCNL due to the smaller sheath. And intrarenal pressures during kind of procedures before do often exceed our kind of 30 millimeter mercury threshold. And even within the same procedure. So some studies, this study was actually focusing on some urinary biomarkers for infection, but they did look at one point, we're looking at their different pressure rates. Did show that the lower your pressure did have a less associated sepsis rate, but their rates for sepsis seem abnormally high to me. So I wouldn't take the numbers for face value, but just to get the point across that the higher the pressure you use, there may be worse associated infection rates. And this one kind of gets to the prior point of what exactly is the injury that we're chatting about with the higher pressure and the higher temperature. So this was an ex vivo porcine model in kind of pigs. They infused India ink inside their irrigation. They ran it for 30 minutes at different irrigation pressures and looked at the percent of tissue penetration on histology afterwards. So with 50 and 100 millimeters of mercury, they didn't see too much penetration, but with 200 millimeters of mercury, they saw almost complete tissue penetration with their ink. And then when they used the ureteric access sheath, the amount of dye that went into the kidneys almost, they didn't see any with the lower pressures and significantly reduced with the higher pressures. From the picture, with under high magnification, they did show kidney tubule damage, sloughing of the tubular epithelium and ink spillage outside the tubules, but what kind of long-term consequences and what ultimate effect this may have on your kidney function still remains to be seen. So with access sheaths and intrarenal pressures, like we chatted, I'll show a bit later as well. But the type of irrigation, whether it's gravity, pressurized, or manual, can play a role. The size of the access sheath and also where the access sheath is located can all play a role, whether it's in the renal pelvis, in your proximal ureter. And with intraoperative suction, there's been an evolving role with its role in increasing your visualization, decreasing residual fragment sizes, decreasing the need for basket, and helping to decrease intrarenal temperatures and pressure. Some of the options are the newer technologies I'll kind of highlight next are steerable suction catheters, flexible suction ureteric access sheaths, which is the clear pressure sheath that we do have here now. And then lastly, with direct in-scope suction. So this is the CVAC system from Calyxo. It's a steerable suction catheter. So it's similar to a Pollock, but it's slightly larger. It's around 7.5 French, and it has this kind of knob on the bottom that you rotate, and it will rotate the tip of the catheter. So you go about your ureteroscopy the same way. You laser everything to your normal dust, and then at the end, you would feed this up through your access sheath, and you would kind of control it under fluoro to get into each calyx and suction it out. They've shown that it's been able to suction up to 2.5 millimeter fragments. This study was their initial pilot study just to show safety and efficacy in 43 patients. And then they targeted patients with large stone burdens at around kind of just under 3 centimeters. And then they mentioned in their pre-surgical consults that 21 patients mentioned that they would need a staged ureteroscopy, but ultimately only 2 patients needed to undergo staged ureteroscopies. They didn't look at stone free rate per se, but they looked at stone clearance rates based on the volume of their preoperative stone burden, and anywhere from 94 to 99% of stone clearance. They further went on to do a prospective randomized study. This was presented by Tom Chi at this most recent AUA. If the pictures look a bit fuzzy, it's because I cropped out all the heads sitting in front of me from the pictures. But this was a multi-center prospective study done across the United States at around 11 centers. They looked at stone-free rate at post-op day 30 on CT scans. Okay. Although it was randomized, the suction group did have a bit smaller stone size, 15 versus 19 millimeters. But their stone-free rates at a month were the same with no difference in the p-value, but their stone clearance rate did improve. And looking at residual stone burden, those that did have stone fragments, their volumes were much smaller at around 14 cubic millimeters compared to around 70, and safety was comparable. But what they did find is if they stratified stone clearance and residual stone volume based upon the baseline stone size, they did see a worsening with the ureteroscopy group, but not necessarily with the suction group. But what I found more interesting was what they showed at the end with looking at 1 year out. They had data looking at secondary retreatment rates and unexpected healthcare visits, such as to the emerge and admissions. And they saw that with the suction group at about 1 year, that rate was around 3% compared with around 13% in the traditional ureteroscopy group. So if there is a difference in looking at secondary retreatment rates, I definitely think that's an improvement or a plus for this. Next are the suction ureteric access sheaths. On the next slide, I do have a couple more images that show you, but it looks like a normal ureteric access sheath. But there's this oblique thing on the end that can attach the wall suction. There's also a small slit on that side, which you can plug your finger with to increase the suction more. And then the distal 10 centimeters is flexible, so you can kind of direct it with your ureteroscope just in it. There's some images on the next slide which do show that. So this study was comparing just traditional ureteroscopy with the suction access sheath. And they're just at the top, kind of the top corner there, that clear suction with that slit you can plug to increase your suction. And it is quite bendable, the tip, such that with a plug you can it's kind of like mini PCNL where you want to get the sheath right on the stone. So you want your sheath much higher than you would have it before. So that's why it's a bit more flexible and a bit more maneuverable. And from the fluoro images, that's actually the sheath and the scope right on the stone. And what they found with this study that the flexible tip did have a slightly shorter OR, improved stone-free rate at 1 day and 30 days. And they also saw less infectious complications, which any kind of postoperative fever, urosepsis, and septic shock. Let me just, before I play this, stop. Okay, so next, these are a couple of videos of patients that we've been treating over the past week or two. So this was a patient who initially underwent or attempted bilateral PCNLs, but was very difficult access on the first side. And then we weren't able to clear all the stone burden. So they were brought back for bilateral ureteroscopies with the suction sheath. So this is kind of the stone burden after his initial PCNL, just on the one side. Playing, okay. And then here's kind of the ureteroscopy. This is in the kidney, and then you want your access sheath right up on against the stone. And as you're lasering, fragments will kind of get sucked into your sheath. And we're doing a lot more of the lasering inside the sheath now. So one, this can help with injury to around the surrounding parenchyma. And then you can probably also use higher energy levels just because you're kind of not at risk, and it's kind of all of that extra heat is being sucked away right away. And also because you're kind of right on the stone, we've noticed that respirations in the upper pole, you don't really notice anymore. And it's kind of, and all of the stone that's getting sucked away, it's connected to a filter on the wall. So you can send that for stone analysis afterwards. Anything that flies back on the screen, it does theoretically get all sucked away, but you will feel it does get gritty sometimes, and then you just pull back the scope to kind of clear the line essentially. And it does take kind of a couple minutes to wrap your head around it, because you're kind of maneuvering the sheath and the scope at the same time now, trying to get it into every calyx.
How much like space do you have?
They come in different sizes. This one's a 12-14 French, I think we use. So it's the same size as the traditional access sheath.
12 is the inner diameter.
Yes, or 12 French. That's the inner diameter. So if your scope's around kind of like 7 French, you have 5 French difference. Kind of around, I think, 2 millimeters. No, or 9.5. So you do it. There's no space there. So this was the before, and then the next slide shows kind of right at the end when we're all done looking at, because normally you get all that dust, you get all that sand everywhere, but essentially here now we've sucked away all of that residual stone fragments at the end. Initially, this is taking us a bit longer because we're trying not to leave anything behind, which you may or may not need to based upon what we were doing before, but we really do think this is a very big game changer. Like Dr. Chu stated, this really making ureteroscopy fun again. This was a different application I want to show you. This is like those complex patients that either the quads or the spina bifida, they don't really move around. You get all that stagnant, debris-filled kidneys that were before very hard to clear, or even those matrixy stones, which you couldn't really laser, and then they would have to undergo a perk. So this was just us putting up the access sheath, the suction access sheath, and turning up the suction, and this is kind of what happens. So it's suctioning everything out, and then you'll see eventually kind of it does clear up. You're not there kind of trying to syringe a 50 cc syringe through your tiny scope through that working channel. It really does help kind of clear up everything. Yeah, exactly. That one at least works a bit better if you hook it up to a wall suction, but just given the smaller working channel, we're actually quite amazing how well this works. I think in this patient, after they suction out, there wasn't actually that much stone left over to treat. And then kind of going down the line, so you see kind of suction catheters, you've seen suction sheaths. So natural progression, I think, is what if your scope itself was able to suction? So we're getting almost to that point. There's been a lot of advances in flexible ureteroscopy since they were first introduced kind of back in the 60s. But most modern flexible scopes that you're used to kind of back in the 90s was the first time they appeared in. 2015 was the first disposable ureteroscope. But since then, there's been improvement in imaging and flexibility. They've been tapered distal tips. They've tried to go smaller. And now there's new ones with both pressure and temperature control. This is the LithoVue Elite. So it's the first single-use flexible ureteroscope with pressure sensing. No suction on this one, but this was a lot of the work was done at the Stone Center here. And then I just wanted to highlight some of the pressure readings they saw from a lot of the porcine models that they saw. Intrarenal pressure was, a lot of this seems like common sense, but they just didn't have an accurate way to measure pressure up until recently accurately. They found intrarenal pressure highest when no access sheath was used. And as you use larger access sheaths, they did see lower pressure. So a 12-14 French sheath did have much lower pressures than an 11-13 French. They found intrarenal pressure highest when the sheath was placed just below the UPJ, and pressures were the lowest in the renal pelvis. The UPJ, placing the sheath below the UPJ was even higher when you compared with like leaving the sheath in the middle or distal ureter. And intrarenal pressure was higher with higher pressure irrigations, but highest seen with manual irrigation with syringe. They did the first in human with the LithoVue Elite studies here. And here, I won't go too much into details just for time, but just want to highlight that they broke it down to see how often during a procedure you're over certain thresholds of pressure. They found the median intrarenal pressure was just around that magic threshold of 30 millimeters of mercury, but they did see spikes here and there jump up to almost around 200 millimeters of mercury. I don't know if you were watching the sidebar on the prior videos, but it does give you a lifetime reading of what the pressures are. And sometimes you're rubbing up against the side of a calyx, or if you're in a narrow calyx where the irrigation can't get all the way out, you can't see spikes in your pressure. But on average, they found that for 91% of the case, the pressure was less than 60 millimeters of mercury, which is still above kind of that magic threshold. But patients without ureteric access sheaths or tight ureters, the pressures were significantly higher. And throughout the case, you were at higher pressures for larger proportions of the case. This is the Poussin scope. It's a 7.5 French scope with an integrated suction channel. They showed this at AUA. There was an in vitro study looking at calcium oxalate monohydrate stone phantoms. So they had stone phantoms of varying sizes from 63 microns all the way to 200 or 2 millimeter fragments. And they show they were able to clear 100% of particles if it was less than 250 microns, with the highest clearance rate if it was smaller than 125 microns. This is with a 3.6 French working channel, which is kind of what we're used to on our normal scopes. But with larger stone fragments, they did have scope blockages and mentioned that they had to like flush to clear out the scope. So still in the early steps. So what happens if you go bigger in your working channel? This is the CVAC scope from Calyxo. This is the same company that had that steerable catheter presented initially. This is a 7 French working channel with kind of passive aspiration during lithotripsy and also a trigger for active aspiration. So if you can imagine, if it's a 7 French working channel, the scope itself is almost 10 French. So larger than what we're used to now. And it's actually interesting. Going on the Calyxo website, I really can't. All evidence of their suction catheter has kind of disappeared from their website now. So it seems like they've shifted all their marketing over to this new scope now. It will be interesting to see with the studies, kind of if this eliminates the need for an access sheath, given this is already so big already, you're probably not giving that much flow around the access sheath. And I heard the costs of this single-use scopes are quite astounding. From what Dr. Chu told me before, he's heard anywhere from the range of a couple $1,000s for a single-use scope compared to the single-use scopes we use now, probably a couple $100 based upon, or maybe some, yeah. So where's this all headed now? We kind of talked about this a bit at Journal Club, that with these newer lasers, scopes, and suction, a lot of people are kind of trying to pushing the limits of what ureteroscopies we can do, pushing kind of the sizes of stones you can treat. And it's kind of encroaching into the territory of mini PCNL range type stones. So this study compared ureteroscopy with suction and compared it with mini PCNL. The mini PCNL, they also used a suction sheath as well. It's similar to the Cleopatra sheath. It's just shorter. You just do your mini PCNL with that suction sheath. So for the mini PCNL, they did it with an 18 French sheath, so slightly larger than the 16 sheaths we used here, but they were also able to connect that with wall suction. And for the ureteroscopy, used the 12-14 French sheath, connected that to wall suction as well. They actually used different lasers for the two sides of this study. For the ureteroscopy, they were actually using the Moses to help better kind of fragment the suction fragments to kind of suck that all away. And they used the Homium one in the mini PCNL. But the main point, they didn't find a difference in their OR time. Their stone clearance rate was equivalent between the two groups and similar stone free rates. I did want to point out that 79 minutes for a mini PCNL is quite astounding. We did see from a lot of the Chinese studies that they're quite fast with their mini PCNL, so there may actually be a time difference if you performed at any other center. Their flexible ureteroscopy group also had shorter lengths of stay, lower hemoglobin drops, and they saw fewer complications in general, also fewer infectious complications. And putting this all together, where are things headed? I think there's been a lot of talk about intelligent pressure controlled systems where you have a computer kind of being able to sense all of this. So if you have a scope that's able to sense your pressures, and then you're actively suctioning out all your stone fragments, if it's able to analyze how much exact pressure you're able to need to help keep your pressures low in the kidney, that's where I think the future of things are headed. So in conclusion, looked at factors associated post-op sepsis in respects of ureteric access sheaths and intrarenal pressure. There are new single-use scopes that are able to sense temperature and pressure, and there's a lot of exciting new technologies around this that are already here, I think, here to stay. I'd like to thank you all for dealing with the technical difficulties and open to any questions now.